For everyone with an interest in MASH or more broadly steatotic liver disease, surf's up. Season 5, Episode 3, our look back several months later at the nomenclature process, starts now.
Today on Surfing the MASH Tsunami.
The field really needed to unite around a change that recognized that, this is the hepatic manifestation of metabolic dysfunction, and put metabolic dysfunction front and center into the name and have a definition that was more fit for purpose.
We were committed to the outcome of that process, and we were not wedded or specifically tied to any particular outcome. I think that's important because some people will say, well, I don't like that. Well, if you would have asked me by myself, what would I have chosen? Probably wouldn't have been that necessarily, but it's not about that. It was about what the group came together and decided.
As a sort of end user in the Delphi process, like filling out the questions, I did notice like through the iterations, there was changes. So it's not like Maru said, it's the same thing. Here we go again, the same questions. The nuances were there, and you said, oh, I guess that means that they're basing this new question on the feedback they got from the old questions.
The word just is really the kicker here, right? Is that they've said, why am I just have fatty liver? So I think what we've done now is it's a clear disease with risk factors and prognostic implications. So I think that this is another way in which we have to get away from just.
Dropping the just and that conversation, where that took me was to Jeff's Healthy Liver, Healthy Lives, writing back the liver into the story way earlier in primary care and all of those areas. This now opens those opportunities to keep your liver healthy.
Every week, a global community of steatotic liver disease stakeholders comes together to explore the most critical challenges in diagnosing, treating, and developing medications for patients with MASLD and MASH. Join liver health advocate Louise Campbell, pricing and forecasting guru Roger Green, and this week's guests, hepatology researchers and key opinion leaders Maru Rinella, Jeff Lazarus, and Meena Bansal, and patient advocate Mike Betel, as they discuss highlights of the recent and ongoing nomenclature process, this week on Surfing the MASH Tsunami.
This week's episode is sponsored by Madrigal Pharmaceuticals. Madrigal Pharmaceuticals, Incorporated, is a clinical-stage biopharmaceutical company pursuing novel therapeutics for non-alcoholic steatohepatitis, or NASH, a liver disease with high unmet medical need.
Madrigal's lead candidate, resmetirom, is a once-daily, oral, liver-directed THR-beta agonist designed to target key underlying causes of NASH.
For more information, visit www.madrigalpharma.com.
So we are recording on a Thursday, which is not the day that we usually do. And as a result, this will not come up at 10 o'clock Wednesday night because 10 o'clock Wednesday night was last night. But this is when we can get everybody together, or all the folks we have with us. And may have a couple more joining us in a minute. But right now, in order of how long it's been since we've seen them on the podcast, Maru, I think you're the one who's been away from the podcast longest. How you doing today?
I'm doing okay. I'm busy on inpatient service, but good.
Okay,
yeah.
That's a good thing. And then we have Jeff Lazarus, who's on our side of the pond today. Hey, Jeff, how are you doing?
Fine, thanks, Roger. Just got back from some vacation, so that was good.
Excellent. And Mike Betel is in Toronto doing our tour of world cities. Mike, how are you doing today?
I'm doing great. It's great to see everybody, hear everybody.
And then going 14 hours away from here, Louise is still in Perth. How are you doing today, Louise?
Very well, thank you very much. Nice to see everybody again.
We do have a first-time visitor today, Meena Bansal from Mount Sinai. Meena, how are you this afternoon?
I'm doing great, thanks.
So, Meena, do me a favor, take a minute or two, our audience a favor, really. Take a minute or two and tell folks about your background, what you do today, and kind of how you got to this place.
Sure. Yeah, so I joined the faculty at Mount Sinai about 23 years ago, and I've had a longstanding interest in understanding molecular mechanisms of liver fibrosis, particularly stellate cell biology and Kupffer cells, which are the macrophages in the liver. And I specifically also am very interested in understanding liver fibrosis in patients living with HIV. During this time, I've also been the principal investigator on virtually all the MASH clinical trials happening at Mount Sinai, dating back to the Intercept trial, and am currently the director of our MASLD MASH Center of Excellence, and I am the system chief for the Division of Liver Diseases at Mount Sinai.
Well, the week that you assumed the last role of those roles, we actually had Scott Friedman on talking about how delighted he was to be giving it up and how excited he was for the division that you were taking it on. So our people have actually heard about that already if they've been listening to the podcast regularly.
Outstanding.
And we ask everyone when they come on the first time, tell us one thing about yourself that our audience wouldn't know or expect if you didn't tell them.
I taught aerobics in medical school.
That's pretty good. Yeah. That's pretty good.
In the Rockefeller gym. Yep. And downstairs, I was at Cornell Med School and used to have an aerobics class in the basement there in the gym.
Do you still do a lot of aerobics now? You have time for it?
No.
Okay. And why don't we just start real simply? What we're going to do today is we have two of the primary architects of the nomenclature process, Maru and Jeff, here with us. And Mike is a patient advocate who's been supportive throughout. And then Louise and me, because we're always here. Just want to start with simple Groundbreaker. One good thing that's happened in everybody's lives in the past week. Brave one, go first.
I will. I wanted to share that Fatty Liver Alliance has a new collaboration with AASLD with a formal patient synergy partnership. And so that's pretty exciting because it means that we can work together and make a bigger impact globally and work that synergism.
That's great.
Fantastic. That's excellent. And congratulations on that.
Thank you.
Okay, Jeff, go ahead.
Well, on the personal front, I just got back from a very nice trip to Puerto Rico. And on the work front, I co-chaired the first steering committee meeting of the Healthy Livers, Healthy Lives initiative that brings together AASLD, EASL, ALE, and APOSL in an awareness initiative, something we've been building for years that I've been dreaming about for years. And we had our first steering committee today.
Congratulations. That's fantastic.
Yeah,
very,
fantastic.
very exciting and very holistic, which is holistic and from the right side, which is health, which is a good thing. Okay. Maru, Louise?
We're sitting in the AASLD area currently. That's great, Jeff. My personal one is I've just spent a few days on the southeast part of Western Australia, which was the coolest part of the state, which was great. From the whitest beaches and with kangaroos on them to back into Perth for a nice temperature boost of 40 degrees.
Okay. Maru, go ahead.
Yeah, so I guess on a personal level, my son got his first abstract accepted to a major meeting, which is kind of exciting. And professionally, I don't know, may have an exciting opportunity on the horizon. Other than that, that's what I have for you.
No disclosure.
Cliffhanger.
Nope, that's the secret.
Okay,
Yeah.
so obviously, Maru, this means you're going to have to come back within the next 2 years because when this exciting opportunity comes through, we're going to have to ask you about it.
That's right.
That's a good thing. Anytime we can get you here, we're happy to have you. Personal note, went to theater in New York last night, which is always a fantastic thing to do. And saw a preview of Doubt, which was a favorite play of mine 25 years ago and actually holds up quite well. And I thought it held up, Jeff.
Well, with Tyne Daly out, I mean, the understudy did a nice job. I was there a couple of weeks ago after she was hospitalized. I thought it was good, but not awesome.
So one of the things I've learned is it takes a while for people to get into roles. We saw Amy Ryan 2 weeks later than you did. I thought she was good. I loved Liv Schreiber and I loved Zoe Kazan. And I just like to play. So that's the thing. Professionally, we, after a month off, as you know, came back the last 2 weeks. Last week, we cracked the top 20 in a country for the first time since we've been back, which is a good thing. So listeners are coming back quickly, which is nice. Meena Bansal, who's the sixth person that should be with us, just sent a note saying she had to get her Chrome updated. She'll be joining shortly. And in the meantime, we will get going. So we've talked about nomenclature a couple times on this podcast. I don't recall that we've done an episode specifically focused on it in a while, but it's been, I think, one of the most important things that's happened in the space in the last year. I tend to think of long processes as happening in 3 phases, which is, first of all, design or descriptive, which is you've got to want to do it. And then you got to figure out how you're going to do it, create the process, and then get to a point where you actually, and I think you folks peaked this maybe by last May or June when it rolled out, well, or fall of 22, it rolled out tentatively. Last spring, it rolled out formally at EASL and then went on to roll out throughout the rest of the year. Second major presentation on it at the AASLD. And now we're kind of into the third phase, which is paying it off, which is what does everybody get from it? How's it working? And are you succeeding in the ways that you hope to? I just want to go back kind of one phase at a time for folks who have missed it or for folks who are on the outside and start with really kind of back when. I don't think we've ever sat and talked with anybody about exactly what the driver to do this was in the first place. So, Maru, I think I'll turn to you since you were one of the two people with a steering wheel at that moment, even before Jeff showed up.
Yeah. So that's the hardest question to really answer. But I would just say, I would summarize it in saying that, at that point, we felt like there was a bit of an existential crisis for the field. And that was mostly centered around the proposal of a redefinition of MASLD at the time, which included no boundaries for alcohol use and sort of de-emphasized the role of steatohepatitis. So the role of alcohol is very clearly impactful with respect to impacting the natural history of the disease. So that was a really big deal because it then alters the natural history data that we have, may alter response to therapeutics that are just really on the cusp of being approved and those in the pipeline, and then perhaps impacting biomarker development. So that was the initial impetus for that. And then subsequent to that, there came a lot of discussion around stigma and other issues. So that's sort of what initially started it. And then maybe, I don't know if Jeff, you want to take it from there.
Thanks. Yeah, I think that was really it. The issue of a new name and definition coming in, some reports of patient advocates feeling that there was stigma with some of the terminology, and a sense that the field really needed to unite around a change that recognized that, this is the hepatic manifestation of metabolic dysfunction, and put metabolic dysfunction front and center into the name, and have a definition that was more fit for purpose and not exclusionary or not defined by what it's not.
Jeff or Maru, so that's the impetus. And then you say stigma came into it. What are some of the other things, or as it evolved, what were some of the surprises? And then we'll go into the process.
I don't know. Some of the surprises were, I guess, the difficulty that we had broadly involving people. At the beginning, I felt that people were a bit reluctant even to just be part of the process. And then later it became more like, well, why didn't you involve this person or that person? We really tried very hard to strike a balance between representing stakeholders and having it be a manageable number of people to work with closely, because you do really need to converse, exchange ideas, revise. We were trying to strike a balance. And we went through many, difficult conversations about, well, how do we represent? What's the appropriate proportion? Do you do it based on the amount of KOLs in a different region? Do you do it based on publications and scientific contributions? Do you do it based on societal membership size, population? Didn't seem like the best way to do it. But anyway, Jeff, maybe you can comment. To me, that was one of the hardest things at the beginning, I think, and ended up being something that was our biggest criticism, despite really trying to be representative.
Yeah, it was hard to do the participant selection. Like Maru said, in the beginning, it was hard to get people to engage. And afterwards, it was a sort of like, why wasn't I involved as well? And I think people didn't really realize the momentum it would pick up, the support that it would get. But we have a great outcome. I mean, we have three of the largest societies fully endorsing it, 70, 80, I think over 100 now other societies endorsing it. And the uptake, as I know we're going to talk about in a moment, has been very high.
So, question, and then I want to ask Meena and Mike about how they got engaged. But so first, it was hard getting people play, and then after that, it was really, if anything, more people wanted to be involved than you could necessarily absorb. What was the tipping point, and why do you think it tipped? Going from not a lot of people wanting to be involved in the process, being hard to get people into the process, to everybody wanting to be in the process.
I think there was a realization that, MASLD, and particularly it's not necessarily the name, but at least the new definition was not going to work, and that the field really had to come together. So in the beginning, it's we should do this, and what about this? And I also think, and Maru, correct me if I'm wrong, but people didn't fully understand the Delphi process, the level of engagement, the fact that if you don't agree, you can stay involved, and we discuss and we revise. And we had 4 rounds of this. So there was a lot of discussion, and it started to be the room you want to be in to help name and define the disease that you're working with. And so suddenly more people wanted to engage, but we were already in motion with those, almost 300 people.
I think one of the hardest things conceptually for people was this concept of everybody would agree that, consensus is important. And of course, we want to make decisions based on a consensus approach. But when it came down to it, people had very strong feelings about one thing or another. And the critical thing that I think everybody understand is that we went into this with the commitment that we a priori decided what our thresholds were going to be, and we were committed to the outcome of that process. And we were not wedded or specifically tied to any particular outcome. I think that's important because some people will say, well, I don't like that. Well, I mean, if you would have asked me by myself, what would I have chosen? Probably wouldn't have been that necessarily, but it's not about that. It was about what the group came together and decided. And I think that was something that I think was hard for people to understand.
Yeah, I mean, I think that initially there was fear of being criticized for wanting to change something that we've kind of made a lot of progress in terms of epidemiologic studies, biomarkers, clinical trials. So there was this fear that we're going to go backwards. And when it was clear that we're not going backwards, we're actually going forwards, people wanted to be part of the snowball. They wanted to now be part of it. There was clear momentum growing. It was clear that it was going to change. So you can either stand on the sidelines or be a part of it. And then all of a sudden, everybody wanted to be a part of it. Their feelings might have been hurt that they weren't asked to be a part of it before, but they probably could have rose in their hand. If they knew this was going on early on, they could have said, I really want to be a part of it. And I don't think that would have been thought of as like, no, you can't. If you were clearly somebody who was involved in the field, come on in. But then at a certain point, it's unwieldy. I mean, you can't have 500 people debating in a room. I think that Maru and team, Jeff, did the best they could with the situation. And the outcome has been something that's been very positive, and the uptake has been great.
So, Mike, when were you invited to be part, and what do you recall about the process of enrolling yourself or becoming enrolled?
Well, I received an invitation by email. It might have been Jeff. I accepted because I think it's important work, and I could be wrong, but I think there was 2 online, and then there was one in person that I was a part of. There was one a year before, but I wasn't part of the early discussions of that. But it wasn't even a question. I accepted the same day I got the invitation, so I appreciate being included.
So then you get to the Delphi process. Jeff, you want to take a couple of minutes and walk people through that for those who might not be familiar with what it was or how it worked in this case?
Yeah, essentially, I sent an invitation, but on behalf of the chairs and the steering committee, people agree to join or not, and we have a set of statements, and they have to assess their level of agreement. And if a certain level is reached, like over 2/3, we feel that there's enough agreement to accept it, and if not, we need to discuss and see where there's disagreement. As we started in that process, we realized there were a lot of issues. It was a bit of a fishing expedition that, we wanted to address and understand. Ultimately, we wanted to come up with a name and a definition, but along the way, there were dozens of questions or statements that we were asking people. And so we went through round after round. We also had a call. We also had a meeting in Chicago, a hybrid meeting, so we could discuss among, the participants, how do we find a solution to the name? How do we agree on the definition? And ultimately, we reached the level of agreement. It can be tough, like Meena said, to have 500 people in the room, but you can have a Delphi with 400 or 500 people. We did that for COVID. In this case, we had almost 300, which is a lot of people involved. It's almost 10 times the number that were involved in the Delphi that came up with MASLD. And we felt that it was important to have people from all over the world representing or not representing, their associations, people who are leaders in the field, who have published, who have experience, so they could do this and that we could really get that global agreement. But it's a long, and I think Maru and I would agree, at times torturous process. Like, here's another email from Jeff and the team to do 40 Delphi statements and rank. But I mean, we also changed, it's completely revolutionizing, I think, the field. It's so much easier. I want to hear, Maru and Meena, but I think it's so much easier, at least when I speak to endocrinologists and GPs, when I say this is metabolic dysfunction associated. You're dealing with this already, but this is the liver part that you need to engage with now, rather than non-alcoholic fatty liver disease. And again, Maru and Meena can speak to this, but we also came up with a new disease name. MASLD fills a major gap in the field. For listeners who aren't super familiar with the field, imagine, you're either non-alcoholic or you were alcoholic, as if you couldn't be overweight, obese, and also drinking. Where did you fit? So now we have a category and a plan for how to address that population. And that's revolutionary to be a part of that.
Jeff, I said this to you. I thought that was the best thing in my mind. The single best thing to come out of the entire process was that you could actually categorize that, and that, frankly, we weren't encouraging people to lie or misstate themselves any more than they would do otherwise. Let me ask, just before we go on, in that process, were there people who opted out? Question one. And question two is, what, if anything, could have gone better? And why did people opt out if they did?
So I will say, so there were a group of people that opted out after the third round, because one of the decisions that was made right before the third round or heading into the third round was that the overarching term would be steatotic liver disease. And the rationale for that was that if we could be non-stigmatizing, and you can, it depends on who you ask if somebody perceives stigma, but the way we looked at it and the way the steering committee as a whole looked at it was if some people experience stigma with the terminology fatty and we could avoid that we should avoid that. And that was sort of the tipping point of steatotic liver disease is the overarching term. Those that were big proponents of MASLD were upset about that. And many of them left, at that third round. But maybe, Jeff, you can comment further on that.
Yeah, I'd say many of the proponents of MASLD left, but not many of the participants in the Delphi.
Correct. It was not even a handful.
Okay, then go back to my previous question. Did people opt out of the Delphi in the first place?
Some did. Not really. I think it was more just people didn't really know what it was. But overall, actually, the opt-in rate was pretty good, actually. I want to say it was like 78% or so, 83% for the second round. Right, Jeff? I mean, it was pretty high.
It was very high. When you're hitting 80%, that's high.
Yeah.
And initially, it's always hard to calculate because people get this email and they're asked if they want to sort of take another survey. And I think we've all gotten that when you go to a restaurant.
No.
Something. People are like, what's this one about? And they don't. So we don't.
I thought I already did this.
Right. It's hard to say that's an opt-out.
It's a passive opt-out.
It's a passive opt-out.
Just didn't read your email.
In AASLD, you had to apply to be part of it. So imagine people are applying to take the survey. That's a dream. And then, in EASL, there was a selection process. And in that, people were incredibly active. In the steering committee, we were talking all the time, and with the co-chairs every day, multiple times a day. We've won back so much time that that's why Maru's back on surfing NASH. She has free 10 minutes every day.
Yeah. Okay. So, is there anything else in that process that could have gone better? I mean, I think you've done a pretty good job of talking about what went well. A lot of participation, a lot of engagement. People stayed through 4 rounds. Answer that was widely accepted. Anything that could have gone better?
I mean, I would have liked to have had more robust involvement, from a broader group of people. I would have loved to have had more patient involvement, but the caveat I will say is that was definitely not for lack of trying. So we had set our limit of participants proportionally to the association size. That was initially what we finally decided to do, but we left the patient participation portion open. So as many patients as wanted to participate could have participated. I suppose we could have capped it 267, I suppose, but we didn't. We just left it open. And we had a hard time getting patients to be participatory. And that was despite, I would say, pretty concerted efforts to get them involved. So that was, I think, the one thing I really would have wished we could have had more robust patient involvement in the process.
I might add, I think the other thing that maybe would have been good is to have a little bit more of those who are KOLs in the alcohol-associated liver disease, because I think some of what we are dealing with now later is, yes, huge advance. Like having a category of Met-ALD, I think is going to be transformative for the field. Those patients have not been included in clinical trials. They have not been included in standard epidemiologic studies. So tremendous window has opened for research and better understanding the interaction between these diseases. But that, I think that clear definition, maybe having a little bit more of those stakeholders at the get-go. But I think, it evolved, right? Like, I don't think that was necessary. We didn't know that was what was going to come out of this, but it was the discussion that made it clear that this needed to be a new category. So had you had the crystal ball, you would have had more alcohol people up front.
No, for sure. And that's the hindsight is 2020 thing, right? So we didn't set out to redefine alcohol field. That wasn't even in our mind. Actually, we knew that we'd need to manage that sort of overlap situation. But to be fair, on the AASLD side, which is the only thing I had any say in, because it was association based, right? In our association, we sent out an RFA and we did actually specifically seek out alcohol people to weigh in. So on the AASLD side, we had several alcohol experts. That is maybe not what happened in the other associations, but we did anticipate that might be a useful thing to do. But you're right, it would have been excellent to have a much more robust alcohol component, particularly later, right? That would have been excellent. The other issue that we were dealing with is a lot of, pressure to just hurry up and finish this. It took 2.5 years because it's a lot of work and it's very time consuming. So we had a lot of pressure from all sorts of sides for this. I don't know, Jeff, you have any other comments on that?
I like big collaborations. So if I could go back, I would try and have someone from every liver society in every country, at least one person. That gets really complicated. We came pretty close in the research and action priorities, but obviously you get to some small nation states, you get to some countries that don't know who you are and why you're doing this. But, we had a real broad participation, but it would have been nice, I think, if more societies played a bigger role in the beginning than AASLD, EASL, and actually ALE and APOSL itself. It was there in the beginning.
Were instrumental. They were part of it from the beginning.
It might have been nice to have even a few more societies at the society level, bigger societies, whether it's the Turkish Association or the Canadian or
there's also an issue too, Jeff, with the level of contentiousness around this particular topic. It is more controversial than some of the other larger Delphi statements that at least that I participated in with you. So that makes a big difference. If most people are agreeing in the 90s, percentile wise, that's really much a different story than this, where it was like, a few things were 95%, like alcohol, steatohepatitis, but a lot of the other stuff was like 60, 70. It was tough. I mean, it was tough. You had to really try to work with people. And those comments, that accompanied each round of questions, I think, it was well over 2,000 comments that we had to address and, incorporate. It was just a lot of work, really.
Yeah. I mean, imagine you submitted your article, and which we've all done, and it comes back from peer review, and there's 3 reviewers who have 10 or 15 things each, which is 45, and that's a lot. Now you got 2,000. So that's why it took so long.
Well, I think the other question is, one might ask, well, why did you do this now? Like, why now? And I would say, really, the MASLD group is responsible for actually initiating this process, because it was like a runaway train, right? Like now it's starting to show up in publications like, wait a minute, hold on. Who said we have a new name? Because it was done in a different way. And I think that to their credit, they identified, calling it what it is rather than what it's not. And with the caveats we've already discussed, that's why we were doing this now. And it was a bit of a rush because we needed to kind of rein it in and make sure it was done properly and transparently.
Meena, thanks. Before we go on to rollout, it's the rollout process itself. Mike comments, Louise comments or questions, or either one of you comments or questions.
I was just going to add that as a sort of end user in the Delphi process, like filling out the questions, I did notice like through the iterations, there was changes. So it's not like Maru said, it's the same thing. Here we go again, the same questions. The nuances were there, and you said, oh, I guess that means that they're basing this new question on the feedback that I got from the old question. So I did perceive that. And I liked it actually, because it seemed like a version 2, and then a version 3. And so that helped a lot.
I suppose my main comment is congratulations in the first place for pulling it all off, because the description sounds greatly difficult. The one comment that I would have is strengthening the allied health presence, particularly in nursing, who are the patient's advocates by training. Do you think that's something, if this was to be done again, that would be a strength? And I know there's not the KOLs in nursing often that there are in the physician's world, but whether or not that would be something, and certainly dietitians or allied health just generally in the process.
Where I think their involvement would be most instrumental would be in the more rollout and developmental part of the process, because initially the Delphi process really is supposed to be mostly experts hashing out the nuances of the disease. And I don't know if including more non-experts would have really been the best choice in this particular process, because there were so many areas that we were talking about, what causes steatohepatitis and how does this impact the natural history. And I think it really needed to be heavily weighted on KOLs. But I do think at the later phases, during the discussions, for example, during the meetings, I think that would have been a good place for that. That's where the patient voice was mostly heard, actually, is in those meetings, those in-person meetings too.
We did have some allied health professionals, because we do have some physician assistants and NPs that predominantly take care of patients with liver disease. And so I do recall there were some members in the Delphi process for that. But I think that allied health professionals are critical in thinking about how do we talk to patients about this disease, because they're often the deliverer of that message, or the one who has to, they heard it from the doctor, but then they didn't hear it really, and then they need to understand understand it better. And so to Maru's point, now the implementation, delivery, they're absolutely critical in helping patients understand the disease.
So when we come to that, Meena, thanks. I want to talk about how their voice comes into the broader discussion at that moment. But Louise, other question or follow-up or move it to rollout?
Maru's answered the particular question at the beginning about the processes of how diseases formate and where nurses potentially sit. And I think that was correct. And that's the clearest definition that I've heard so far as to why that process wasn't there. And I think I also agree that probably that later stage, and it is going to be the rollout, we are the translators of what gets said. And if we don't have a full understanding of that in various areas, that makes it more difficult, particularly with the new medications that are potentially about to be approved. And I sit across two fields. I sit across MASLD and MASLD. And I've certainly seen something recently here in Australia about now the discussion has been highlighted again as to do they change the name of MASLD. So we're on a circular treadmill.
So my next question is, so when do we transition from actually creation to rollout? In your minds, when did the rollout start? And by the way, has it ended yet? Or when does it end?
The rollout has not ended, and it definitely started before the publication. We already heard some people wanted to be the first to rename their clinic, the first to start using this, the first to start publishing. I just looked, and this is the articles were published simultaneously in AASLD's Hepatology, EASL's Journal of Hepatology, ALES Hepatology Journal Annals, and it has over 650 citations. The alt metric is through the roof. When you combine the three, it's over 1,000, which means it's been picked up. I can see in blog posts, in Wikipedia, in the news as well. So we want to keep sharing this. The more we share it with the general population, which we can measure a little bit through the alt metric, the better we are at raising awareness, because we have to remember there's a goal to all of this, which is to raise awareness, to educate the population, to educate clinicians and healthcare providers who don't know a lot about this and improve patient outcomes. The citations is nice because it means that people are using it and recognizing that there's a new name, but the alt metric tells us that it's actually on Wikipedia and newspapers and so on. So this rollout, it's moving quickly. I think it needs to go faster, and I think it's going to be a long time. I mean, as was just mentioned, in Australia and in some places, they're still not sure which name to go with. During Healthy Livers, Healthy Lives, we talked about the ICD process. That's the International Classification of Diseases. That can be a 3-4 year process, but WHO is aware that the world is changing the name, and we start with these national processes to submit name changes because that's related to reimbursement, that's related to coding and tracking and so on.
So, Jeff, does it start in your mind then with the publications, the rollout, or does it predate that in any way, or postdate that?
No, it definitely predated. As I was saying, if the publications were really in June, EPUB ahead of print, and then some of the print versions came out in the autumn, the rollout was already starting in early 2023. Like I said, some practices were starting to change their name formally and informally, and thinking about how to incorporate MASLD and steatotic liver disease in the language. Some are still using a slash, which is fine. As it would be a pity if people didn't go to get a test because they never heard of this disease and they were going for their NAFLD and walked in and walked out again. So there are different ways and speeds to do this. So this is going to take a while. It's like when you hear about a company changing its name, and for a long time, you probably remember the old, whatever it was, Datsun, now we're Nissan commercials. It's a process to change a name. But the leading societies and many other societies around the world have committed to it. And I think that's fundamental to the rollout process.
And I think the participation of the journals has also been really good. And many of the top journals have accepted it and have endorsed it, and some are only accepting that terminology right now. So I think that there's progress on the part of journals. I think that we've made some progress, and Meena's been very involved with this as far as ICD code changing in the United States. So we're at least started that process, and hopefully that will be successful. We're certainly hearing people using it a lot more. When you go to conferences all over the world, it's being used, so I feel like starting with health professionals, and I do think that pharma has a really keen interest actually in spreading awareness. This is almost, you could argue it's terrible timing, but I actually think it's really good timing because they really are investing in efforts to spread awareness. And I think this is an opportunity to also spread awareness of the new nomenclature.
So I should mention this episode is sponsored by Madrigal, which might go to your own to point to some degree, Maru.
I didn't know that, to be fair, just so you know.
No, none of you knew that. I normally don't tell people who's sponsoring when somebody's sponsoring, but it seemed at that moment to be a germane comment comment to make. Mike, you brought a small piece of data with you on this subject, huh?
Oh, I just thought that the group would enjoy. So Jeff is one of the co-investigators. We're doing a primary care survey in Canada with almost 27,000 physicians. So we had to do, setting it up to test out the questions and that. So we just did 25 physicians, but I just thought it was interesting that 64% were not aware of the new nomenclature. So I don't know if that's good or not good yet for primary care.
I'd say 46 were. Let's go glass half full.
Yeah, I would say the flip side. I would say almost 40% were. That's actually amazing.
Okay, I was where you were. I mean, first of all, I translated into numbers, and what that means is 9 out of 25 knew it, right?
Yeah.
A bigger number than I would have guessed.
Yeah, a lot of people don't even know about NAFLD or how to risk stratify it. I mean, that's the crazy part is that, we were not doing a good job before. So we can only do better than what we were doing with NAFLD. So that's actually not too bad.
Jeff's going to say, hold on a minute, the sample size is way too small. It's very biased.
I think I already said that, but anyway.
You got the early adopters. Yeah, you're skewed to early adopters.
Just a test run. I'm prefacing with saying it was just a test run, but it'll be interesting to see what we actually get back.
Well, I think the key is who's your audience. So I think early on you have high uptake now from hepatology and gastroenterology. So those that are in the specialty have been hearing about this even before the publications came out. I think that they were the ones, obviously, the first ones to know. And then there's going to be a gradual rollout to the specialties as we go. And I think that's where, primary care, there's a lot of effort to educate primary care right now, really for screening and risk stratification. So it's a good opportunity. At the same time, you're kind of saying this is metabolic dysfunction and downstream effects on the liver.
Meena, so Maru was talking about before, like at conferences. So we just had our second annual primary care NAFLD and NASH summit, and every single presentation was MASLD and MASH. So it was because we had pre-named it and already planned it, but all of the speakers switched over like right away. There wasn't any that were the old terminology.
Yeah, and I think the more people see it, it just kind of your mind has to just adopt it over time. And so I think we're getting there.
And I think testimony to that is it's like a funnel. The average person in the street with this condition Googles fatty liver. They're not Googling a definition and a scientific name, and we drill it down. So as they come into primary care, I think we're going to have an opportunity in the UK with FibroScan being rolled out to primary care. And depending on how that uptake is and who is doing those FibroScans, there is that discussion to bring in the full definition very early to primary care if it is the correct people scanning, which are nurse specialists within the field. That is the education of the primary care into liver care, and it's worked very well in Southampton where they've put specialist FibroScan teams in. Primary care become way more aware of liver disease per se, and particularly this new meta-ALD definition. When I'm able to use that in the alcohol screening clinics to say, have you considered having a discussion around this? The patients are very, very receptive to that. It explains it a little bit easier, and the physicians are more open to considering that. So there are lots of benefits, but the real world person that we see who's not been diagnosed still considers it as fatty liver. And they like that simple term. It's just excess fat in the liver. Try not to stigmatize it. At that stage, it works very well to drill down.
Because you know what? I think that part of that is that for couple of decades, they've been told, oh, you just have fatty liver. It was actually downgraded as a disease because they had an ultrasound 20 years ago. And if you look at the ultrasound report, it doesn't say fatty liver. It says hepatic steatosis. It's steatotic liver disease. It's been that over decades. But when we translate it to patients and we say, and that's the word just is really the kicker here, right? Is that they've said, why am I just have fatty liver? So I think what we've done now is it's a clear disease with risk factors and prognostic implications. So I think that this is another way in which we have to get away from just.
I think that's a really interesting point, and that's got two reframes in it, right? One is just, and the second is, does it matter really whether you describe this to a patient as steatotic liver or having fat in your liver, as long as you take the just out of it so the patient gets it.
Well, not only that, what happens in an office between a doctor and a patient and how that patient then tells their family members what their disease is two different things. So as physicians, we always use certain terms to try to make technical terms understandable. So you don't say osteoporosis, you say thin bones. When you're explaining it to your patient, you're translating that medical term into something that they can understand. But the difference here now is, why do you have the fat in your liver? Why do you have the fat in the liver? Because you have underlying metabolic dysfunction, as opposed to it's not your fault, you just eat too much. It's not that. There's metabolic dysfunction as a driver. So I explain that to people, that you can use the word fat, but when they have to go then tell their family members what they have, I have metabolic dysfunction and that's causing fat to deposit in my liver. And in me, that's causing some inflammation and scarring. So I need to take this very seriously.
Yeah, that's great. That's fantastic, I think. So we now have MASLD. How does that roll out to doctors and to patients right now? How is that working? I assume people are getting it, but what are they doing with it?
And I think that's where the research, where it's so exciting, because now we can actually characterize those patients. So, for example, at Mount Sinai, we have our MASH longitudinal registry, and previously, we had audit C and excluded patients with moderate alcohol consumption. We've now opened up our registry to allow increased amounts of alcohol consumption so that we can start to study this population more clearly. So I think this is where it's more enrolling these patients in clinical trials as they evolve, enrolling these patients in longitudinal studies to understand their natural history, because we really haven't studied it.
Okay. Thoughts?
I also say that there's a lot of excitement in the pharma industry as well over this particular disease, this entity of MASLD. And there are studies being developed for that particular population of patients that were not being addressed before. So that's really cool. And as it turns out, there are a couple of drugs that are in the pipeline, mechanisms that really actually make sense for that overlap condition, where you can, impact cravings and things of that nature, and in others where you can actually preferentially reduce the impetus for scar tissue formation and things like that. So there's a lot of excitement over it, for good reason.
So Louise, you were the other obvious head nodder. What nodding your head about?
I totally agreed with Meena on that, dropping the just, and that conversation. Where that took me was to Jeff's Healthy Liver, Healthy Lives, because when we talk about disease, and I was having a conversation with somebody who was doing pathology yesterday, they only look at the the later stages. We've had an unhealthy liver for an awful long time to get disease in most disease states. So writing back the liver into the story way earlier in primary care and all of those areas, this now opens those opportunities to keep your liver healthy. It helps your life. It's the conductor of your body symphony. And people that I engage with who aren't there because they're here from biomedical route really engage with understanding the role of the liver, the regenerative capacity, Mother Nature's first organ, because it's the only one. So bringing it back to how it affects their life, just generally that conversation, they engage in that very well. The opportunity to research MASLD, particularly in cardiovascular areas where alcohol is probably just as unrecognized in that development, now opens all of those opportunities, because I see an awful lot of, as we all do, people who have cardiac or atrial fibrillation who just have those areas of steatotic points. So I agree with it all. So I'm going to carry on nodding because it's been a fantastic process and difficult at times. I know.
Go ahead, Meena.
On this MASLD, I think the fascinating part, and this was actually a comment that resonated me with a patient advocate. Jen Jones made this comment in an email. Right now, we're talking about, those who have metabolic dysfunction and have moderate alcohol drinking. Take it from the other side. Those who actually you're treating more for their alcohol-associated liver disease, but they have metabolic dysfunction, right? So you have to look at how are they entering the system? They're entering from both sides. So we shouldn't just be thinking about those who are entering from the metabolic dysfunction side, but those who are also entering from, they've been more honest perhaps. And so we're looking at them just but we're ignoring their metabolic dysfunction.
Interesting.
I think it just heightens awareness for the complexity of caring for a whole human being, right? So you have to just not be so, blinded into managing approaching just your particular niche. It really is, you need to look at patients more broadly and address their issues holistically. And that includes all of these things that we're talking about.
So, but Marie, that's now two dimensions on which we're talking about being more holistic. One is the idea that because we're talking about a metabolic condition, we're not only in the liver anymore, but the liver is part of a broader system of multiple organs and multiple diseases. And then within the patient, looking more multidimensionally at what it is that might get the patient to where they are right now. So I'd not thought of this description as being the equivalent of three-dimensional chess, but you can kind of get there from here if you play it that way.
The approach to every patient, as Maru said, is it has to be tailored because it depends on what's the most critical issue with that patient at that time. So they may be dealing with an endocrinologist first, as an example. And I have heard at some of the conferences we've gone to, it depends which door in the hospital they go into. That's the one that they're going to spend most of their time.
So let me ask one question, and then we'll roll towards wrap up because we're kind of at the bottom or top of the hour, depending on how you want to look at it. We've mentioned pharmaceutical companies a couple of times. What implications will this have for diagnostics? Do you see in the new definition any at all?
No, it's been looked at. The cohorts, when you look at the definition of MASLD and the previous definition of NAFLD, it's in multiple cohorts. It's close to 99% overlap. So it's the same disease. So it doesn't change biomarkers, epidemiology, or clinical trial endpoints.
What do you think, Meena, if I can ask, if you start with, high triglycerides or diabetes or high fasting glucose, a lot of the population, like when you look at NHANES, is going to need to be tested for steatosis. So the definitions ultimately, when we look at the NAFLD and MASLD are largely overlapping. But when we talk about going into the population, like who's at risk, does it make it more complicated? Will we really need to test so many people? How do we prioritize?
I don't think anybody's advocating. I don't think you can really screen on a population level purposefully. I think that, you need to have a heightened awareness in high-risk groups. But I don't think that we can, and in high-risk groups, screen those patients. But I don't know if at a population level, if it's going to result in more work. Is that what you're asking?
A little bit, yeah. So is AASLD recommending screening then in all people with diabetes type 2?
I think diabetes is actually the perfect place to start, quite honestly, because it's defined. You know your population. You either have diabetes or you don't. And that's obviously, they're a population that are attributed to primary care doctors. So primary care doctors know their population. There's already emphasis on testing for end organ damage. So people have to look for diabetic retinopathy or eye disease, diabetic kidney disease, diabetic hepatopathy, diabetic related liver disease. So I think from a rollout perspective and getting buy-in, that's the perfect place to start. And then that will start to, to the other having at least one metabolic risk factor.
And that was already recommended anyway. So even in our guidelines last year, we recommended that diabetics be primarily screened for advanced fibrosis because they're at such high risk. So that was already out there before the nomenclature thing even came out. So this just elevates it, I think, more, the importance of that risk.
Yeah, that was going to be my question, is whether specifically that, which is whether, in fact, as you redefine the disease so that it's not just diabetics or have a high probability of getting this, but they seem to have a more common foundation. Do you believe over time that will make it easier to motivate or more motivating on its own for doctors to screen?
I think the more ways that we highlight the association between the most impactful risk factor, which is diabetes, and the presence of fat in the liver or steatosis, and drive home the point that that patient is at risk for advanced liver disease, I think the awareness will start to go up, because even in endocrinology clinics, endocrinologists are often not aware of that being such an important risk factor. There's a misunderstanding that if you just treat the diabetes, their liver will be fine. And that's, of course, not true. So I think that every little thing will hopefully end up in more awareness in those high-risk patients, particularly.
I think there are different questions here, and it depends which question you ask. If you ask, is screening for liver disease an effective way in population screening to find liver disease, so very specific, then the answer is probably no, and it's exactly targeting the diabetes population. If we then take the research and develop into the Healthy Liver, Healthy Lives sort of programs, is screening for a metabolic risk factor in the liver that is intrinsic to the development of and many type 2 diabetics, those with cardiovascular disease, which are the two of the biggest leading causes of lives lost, and the liver is a component of that, that is a different question. And screening very early for something that patients and people engage with that changes their liver to change their lives, given that it's the second leading cause of working lives lost in Europe. That is a different question. And that's the question we should be asking the politicians and healthcare, not the end-stage organ disease. Because by looking earlier, we can avoid the end-stage retinopathy. We can avoid the end-stage vascular. We've got to be looking earlier for metabolic health.
You're absolutely right, Louise. The issue is just resources. That's the only major limitation with that. But you're right.
So, question, as we start to roll towards the end, what will we see in this process 1 year from now that we've not seen to date? How do you see the rollout and the acceptance and adoption of this entire thought pattern emerging over the next year?
I think with the approval of a drug, that will really help, because I think that when primary care endocrine can say something other than, exercise, diet, etc., that there's actually now a therapy and they want to link their patients to care, I think that will really help increase awareness over the next year.
Okay. Anything else?
I see continued uptake by more and more people, and I see not just people switching from NAFLD and to MASLD, but people going from nothing, because they don't know about this, to MASLD. Because this is our moment to raise awareness about the disease, not just promote name change. I mean, we need to move now into awareness raising about metabolic dysfunction associated with steatotic liver disease. And if you're in a clinic and say that means you have excess fat in your liver, or you want to call it fatty liver disease, that's fine. But patients can also go home and say, I have MASLD, it's a liver issue, and these are the things I need to do. We're in awareness raising mode, and I see that going on and on. I hope, within a year, we have even better engagement with the World Health Organization. We're planning an event, a side event at the United Nations General Assembly in September. So I hope we start to see pick up at WHO as well. Because right now, even if it's the leading liver associations, this is very much a bottom-up approach. We need this top-down approach where, like with other therapeutic areas, ministries of health, governments, meet in Geneva and they agree on a diabetes strategy, an HIV action plan. So we need steatotic liver disease. We need parity of steatotic liver disease with other non-communicable diseases. We're not asking for exceptionalism. We're just asking for parity with the other 5 major NCDs.
Curiosity drives knowledge and the desire to learn and grow. And I'm talking about the general population. So I did, while we were talking, just a quick search. Over the last month, there were 5,600 searches under fatty liver that found the Fatty Liver Alliance's website, and 99 for steatotic liver. So a year from now, I imagine it's going to be more balanced as people start to look for what is that steatotic liver that we keep hearing about. So that'll be one. That's an easy thing to measure.
Yeah, or that the fatty liver search automatically takes you to MASLD. In other words, it automatically directs you to that. And I think that would be great.
Well, Google, if you like, I showed somebody at the meeting. So if you search MASLD, it says, did you mean NAFLD? That's the best lie ever.
That'll be one test that things are changing. How when it goes the other way around, when NAFLD doesn't mean MASLD. Meena, what do you think might happen with ICD codes in the next year, and what impact will that have on how anybody thinks about this?
Well, I think the goal is really to have the same code be applicable, whether you code NAFLD or MASLD, because we don't want any confusion right now in this transitory period, and we don't want payers giving us a hard time. So I think the goal is that we want to MASLD equals NAFLD equals the same ICD code, NASH, MASH, ICD code, and the downstream complications. They should be equivalent from an ICD-10 perspective over the next couple of years.
Yeah, currently there's no plan for MetALD to be its own ICD category, at least not from our initial submission process. So.
Thanks, Maru. In my public speaking days, I used to give people $1 if they anticipated the next question, so you're $1 ahead right now. That's great. Thank you for that. Just in closing, if you had to look at this entire process and give it a grade against expectations from what you might have expected when you went into it, where would you put it? What would you grade it? Brave one, go first.
I'd grade it high. I'm pretty biased, but we set out, to change the name and to get global buy-in. We did that. We realized we needed a MetALD. We did that. More and more societies have taken this up. We've leveraged this for a side event at the World Health Assembly, a virtual side event at the Executive Board of the World Health Assembly. I think it's gone great. I would, if there were things that could be done better, yeah, it took a really long time. So, but process process was incredibly important. It wasn't just the outcome. It was having an engaging, transparent process. Everybody knew what was going on. Everyone could see those results and where there was disagreement and who was involved. And I think that's what sets this apart from any other similar process related to MASLD.
So if we're grading it, is that an A or it sounds like not quite an A plus because it didn't go fast enough, but is that an A?
I would give it an A. We have a name and we're happy with it. But again, I'm pretty biased.
I think we've got mostly champions on this call, so I wouldn't expect. Yeah.
No, I mean, maybe an A minus, right? Maybe an A minus, but we're still in the in the A range.
I was going to go with an A minus too, Meena.
Yeah, no, I mean, considering how difficult the process was and how many disparate views we had, and people we had to bring together. I mean, I actually think it's turned out much better than I would have anticipated. And so you can always pick it apart, but at the end of the day, we were very purposeful about our process. We were transparent. We talked and had open discussion with people. And I don't know if it's realistic to ask that would have been done better. We really did it there's no example in the medical literature that I'm aware of that's done a more robust job at this. It's something this controversial, essentially. So I don't know. So I think we've done. I'm going to give it an A. Yeah.
So that's a high A. Maybe even an
Solid
A plus. High A. Okay.
The fact is we have a new name. The societies have adopted it. Journals have adopted it. It's been on the cover of our society journals. It's been on the cover of related society journals. And I think our success is that when you talk to people and you say, have you ever heard of MASLD? And they say, I've heard of it. I don't really know exactly what it is, but I've definitely heard of it. And 5 years down the line, everybody's better been heard of it. And if they're in a risk group, they better have been tested or we failed.
That was going to be my last question, which is, okay, that's an A now. What does an A look like in 5 years?
Or whatever you want. New York is not going to get me 5, but thanks.
You get the second $1. That's right. What does an A look like in 5 years? Everybody's heard of it. Everybody's getting tested for it.
Nobody even remembers that this happened in the first place. That's what I would consider to be an A, that the change, it's already changed. Nobody even thinks about it again. Nobody looks back again. That would be, to me,
I think a quality measure for screening would be an A plus in 5 years.
Oh, for sure. Yeah.
There you go. Okay. Hey, this has been a great conversation. Thank you, everybody.
This week's episode has sponsored by Madrigal Pharmaceuticals, Incorporated, a clinical stage biopharmaceutical company pursuing novel therapeutics for non-alcoholic steatohepatitis, or NASH, a liver disease with high unmet medical need. Madrigal's lead candidate, resmetirom, is a once-daily, oral, liver-directed THR-beta agonist designed to target key underlying causes of NASH.
For more information, visit www.madrigalpharma.com.
And now for the Season 5, Episode 3, Business Report.
Slava Ukraini, glory to Ukraine, and also Am Yisrael Chai, the people of Israel live. As I write this on Friday afternoon, the Russian government is refusing to release Andrei Navalny's body for burial unless his mother agrees to a private funeral. While the people who read the highly propagandized version of the news on Russian television are already threatening Navalny's daughter and widow with a fate similar to his if they lead resistance to Putin. In the U.S., Putin's acolytes Trump and Johnson refused to allow a vote on aid to Ukraine and Israel that would surely pass and deliver the military aid Ukraine so badly needs to continue its brave and potent resistance. And in Israel, it appears the only way to free morally innocent Israeli hostages may be a bombing of equally innocent Palestinians who Hamas uses as shields. It would be a good start for Hamas to give up the hostages and Israel to agree not to use so-called dumb bombs in its war arsenal, but really all we can do is hope and talk. Charoyim Slava, glory to heroes, and also, again, Am Yisrael Chai, people of Israel live.
Thanks again for welcoming us back so warmly.
Downloads for both of our first 2 episodes of Season 5 grew nicely during the week, and we hit the top 250 list in more countries in Europe and Asia. All good news. Thanks to those of you who have stuck with us and returned, and make sure to tell your friends about our return and the exciting episodes we're producing now.
Sorry about this, but Question of the Week will start next week, not this one.
Because we wound up recording the Nomenclature episode Thursday, posting it Friday, with conversations to come on Monday and Tuesday, we didn't have the full week schedule we wanted for the first question of the week, so we put it off. Instead, we'll post it Tuesday afternoon, along with videos of the question on LinkedIn, Instagram, TikTok, maybe a few other sites. My descriptive video should come out Monday afternoon or evening. If you subscribe or are on our mailing list, you'll get a link to the descriptive when it comes out. We've already collected 3 questions to start with from friends and colleagues, so that part's off to a good start. Ready your questions soon, and we can't wait to see how you react to next week.
Speaking of next week, our topic will be epidemiology.
Diabetes Spectrum recently posted an article from Zobair Younossi and Linda Henry titled Understanding the Burden of Non-Alcoholic Fatty Liver Disease, Time for Action. Consistent with today's discussion, it might have been more opportune to have referenced MASLD in the title. But as our panelists have noted, all this is a process in transition. At any rate, Zobair Younossi will be joining Jorn, Louise, and me next week to discuss his article and other related work from the Global Liver Council. We may have one more guest as well, but that's going to remain a mystery for now.
This week's Vault Conversation comes from our nomenclature coverage at AASLD 2023.
Our coverage of AASLD 2023 included a 15-minute discussion with Jorn, Louise, Ian Rowe, and Sven Franke, focused largely on nomenclature. In view of the progress our panelists discussed today, I thought it would be interesting to go back to that earlier set of impressions and see what you think. So that's it for this week. I want to thank our team, Jorn, Louise, Mike, Eric, Steve, as we all march ahead into the brave new MASH world of 2024. I've already described everything we've got up next week, so enjoy this episode, the conversation Sunday and Monday, and check for our Question of the Week updates in episode 4 early next week. Until then, stay safe, surf on. Bye-bye now.
Have any questions for the surfers? You can send them to questions@surfingmash.com and we will answer on the podcast or website. Your question might even wind up being the question of the week.